I'm Sarah Russell.
I'm JQ Walker.
I'm Hind, and we are
The Neurodivergent Report, a research-based podcast by and for neurodivergent brains.
In each episode, we'll explore topics relating to neurodiversity and coping strategies by reviewing the literature and discussing current topics.
We will also have interview episodes where we sit down with experts in the field and listeners like you, with the hope that together we can all learn to heal in community.
However you are able to engage, thank you for being here. I had a doctor tell me to stop sitting like that. It's like,
oh,
I'm just sitting.
well,
Yeah, I'm trying to understand the second episode. We were going to talk about treatment here, but I'm seeing us diving more into thoughts.
there's no standardized treatment. I'm kind of going to cover that.
More just like symptom management,
Yeah.
instead of treatment.
I mean, the best recommendation is to have a multifaceted team, but you have to have the resources for that.
yeah.
So that's kind of what I'm going to go into a little bit.
I actually love this as an introduction to this episode because totally. Welcome
everybody.
back. Hello everyone for another research focused episode of the Neurodivergent Report. I am here again with the entire team on deck.
Yeah.
Say hello, team.
Hello, team. No, I know.
31 years. Just now, I knew this. I thought everybody's thumbs were like this. Anyways, hello. How are you?
Hello. Welcome back. Hey guys, I'm JQ. Excited to be here.
Hey, I'm Hind. Really excited to be here.
Wow, had to one-up me.
Today we are ready to welcome back into the ring Sam Silverman,
Yay!
a very special friend and
Yay!
guest. Yay!
Thank you so much for having me. I'm doing research right now, and I intend to get a PhD. So we're just talking about everything that I've been diving into for the last few years with EDS and the ties to neurodivergence and how it affects our body.
Yeah, and part one was focused totally on like what is EDS and hypermobile and what are the connections. If you missed that episode, definitely go back
Check
and
that out.
listen because this isn't going to make any sense because today we are here to talk about like treatment methods and if there's any standard protocols for like what happens when you get diagnosed with Ehlers-Danlos syndrome. Like
What
surely doctors are going to know what to do for you, right?
Spoiler alert. They fucking don't.
No.
No, I'm waiting on the edge of my seat, Sam. Tell me some good news.
Yeah.
So we've come a long way. There are more resources now than there have ever been, but each professional in healthcare, each specialist, they'll have a different method to go about this. They'll have a different level of understanding. They have a different diagnostic tool that they like to use. And then, oh my gosh, you've waited over 10 years on average, and you've seen over 15 and a half professionals on average to get your diagnosis, and you have your diagnosis. You should have a standard procedure for your treatment and symptom management. No, it's still just as variable as trying to get diagnosed. You have different members of your care team, and you have different ways that effectively you try to treat your symptoms. And a lot of that comes down to you figuring out what works for you, which is kind of a huge failure in the healthcare field.
And being able to advocate for yourself to your care team and coordinate the communication between your care team because unless they're in the same like health group, they're not going to be communicating for you.
Definitely not. That's why it's so important to try to form a community to validate and normalize what you go through, but distinguish that from the average population. A lot of us, I think in this recording, we're very unaware of how abnormal our bodies and minds were for a long time. And having access to the right physician or specialist and getting a diagnosis changes your life, not just because you suddenly start to get better, but because you start to accept yourself for who you are, and you start to be kind of retrospective and look back and say, I struggled for a reason.
It's super true. I think sometimes the hardest part to building a community is not knowing like how much we have in common because we're like, you know, the ADHD groups are over here, and then there's like other groups, like autism groups are over here, even though we all struggle with the executive function, even though we all struggle with emotional dysregulation. It just looks a little bit differently. So anyway, so the issue here sort of, I don't know who called it the trifecta, but this episode, we're going to spend some time talking about how hypermobile and POTS, or like autonomic dysfunction, and MCAS, sort of, what is it, mast cell activation, how all of those are sort of the shared community. Like,
Yeah.
it's all like, if you're struggling with one of those, you're probably struggling with all of those. And sort of, in order to support yourself properly, you need to support all of those three.
Yeah.
systems.
So you're not just not neurodivergent. You have connective tissue. You probably have
it's not just my
dysautonomia.
brain?
Your your immune system is dysregulated, and there's an
my stress isn't
intersectionality
just in
to
my
that.
brain, and I can't just like relax?
No,
Yeah.
you're not
Just
just
tell
a
it to
hysterical
calm
woman,
down.
Sarah.
Yes. You're not just a hysterical
I'm gonna,
woman.
It's no coincidence. You might think it is when, for instance, you have ADHD, EDS, and then you have an autoimmune disease, for instance, or you have POTS. You might think these are separate completely, but they're not.
No.
And I feel that helps us, have that holistic approach that you emphasize so much, because that should be emphasized, that this is a multidisciplinary team effort that needs to be taught.
Yeah. And like, so again, like last episode, we talked about neurodivergence and how it relates to hypermobile. But what you guys were just saying is hypermobile Ehlers-Danlos syndrome is also related to POTS, which is postural orthostatic tachycardia syndrome.
Yep, you nailed it.
And MCAS, which Sarah said, mast cell activation syndrome. And they occur so much together that, Sam, you've mentioned a fun little way to talk about the three of them.
So the ultimate trifecta is bendy, itchy, and dizzy.
Yes.
So bendy relates to hypermobility and HEDS. The itchy relates to MCAS and your immune system dysfunction, always thinking you're having an allergic reaction. And then POTS, orthostatic tachycardia, based on your posture. Posture also relating to HEDS, but the dysautonomia, getting dizzy, commonly referred to as the fainting syndrome, right?
Mm-hmm. Yeah. So your favorite three new Snow White 7 dwarves. We got bendy, itchy, and dizzy. So
And then we blame ourselves for being so tired all the time, and maybe our executive function is not top tier. Well, because you're dealing with all of that in the background. Chronic pain is enough to drain your battery,
Yeah, it takes a lot of energy just for me to not pass out.
Yeah, and a lot of
respect that I have shown up today. Thank you.
Yes, and a lot of intentional, not only like to like just be doing that in your body, but a lot of intentional work to symptom manage, like too, like
preventative as well. And then also referring back to the fact that on average we'll see over 15 specialists in 10 years. It's difficult enough for us to even get to the damn doctor's office, because what if we're having pain and fatigue and dysautonomia that day?
Right.
Then we have to reschedule. The doctor's not even going to be available for another 4 months. And that will continue to delay the process, because guess what? We're chronically ill.
Yeah. Spoiler alert.
And that makes me go into, you wanted to, there's a spoiler alert. Let me know what it is.
Oh, no. I was saying spoiler alert to what Sam said.
Okay. No. And this is the thing that I hate about chronic illness, because, for instance, exercise is really important for ADHD, right? Guess what? Yeah, you know, you can't.
Exercise intolerance and chronic pain will limit you from getting all of your energy out.
Yeah.
And not only will you probably miss appointments, work probably, especially if they're difficult, which is most of the time, unfortunately, them being understanding is the exception.
Oh, we'll get into that.
It's going to cause you to, maybe lose your job. And then that makes you not capable of then continuing the care. So it is a population that we really need to take care of.
Well, so did you say the tunnel vision thing already? Because I think that it's an important note, Sam.
Yeah, there's not enough of a holistic, intersectional, inclusive approach to research, diagnostics, treatment, and there's too many specialists out there that have tunnel vision on what they're doing. We're trying to talk about how all these things are related, but in informed healthcare, it's not seen like this. Everything's separate. Everything's a new diagnosis, a new specialist, and a new treatment. And if we have a more holistic approach with the whole person in mind, we're going to have a much better outcome. And that's where we're severely lacking right now.
This is interesting, because in med school, what they taught us is, you're going to specialize in something and you're going to know all the latest research on it, but you definitely need to know the red flags and the most important symptoms of other specialties. And I feel like other medical students didn't take that seriously. And then I was thinking, but this is important. What if you're a neurologist? Okay, but then you have a very dangerous gastric, symptom that, okay, because you're a neurologist, you're not going to be able to refer them or know, what to do.
Mm-hmm.
This is what it leads to, them not being able to pick up things that may be just with a referral. You don't need to do much. All you need to do is pick it up and refer them to the right person. And so I think that's such an important thing, the tunnel vision. We're all trying to subspecialize, and that's great, but then kind of missing the bigger picture.
Yeah.
Do you want to define POTS and MCAS?
Yeah.
So because we kind of briefly mentioned it.
Yeah.
So POTS, postural orthostatic tachycardia syndrome, is associated with when you change your posture, when you often associated with standing up too fast or sitting up too fast, you start to see stars and your veins and arteries will dilate and you start to feel faint and dizzy. It's considered the fainting syndrome, right? And it's really related to an elevated heart rate and blood pressure that occurs when you change your posture. And it can also result in shortness of breath, heart palpitations, and overall it makes things really difficult and often leads to things like exercise intolerance and it can be very disabling. And especially, as we briefly mentioned, during the summertime when you don't have enough hydration or electrolytes and you struggle to regulate your temperature, it can be exacerbated. With MCAS, we have mast cell activation syndrome. Mast cells are immune cells, so often associated with histamine, and it's how your body kind of reacts to emergency situations. So with MCAS, just like how when you're neurodivergent, your nervous system is always on high alert. Now your immune system is really on high alert with MCAS, right? So you have these surges of histamine. These responses are basically saying you're allergic, you're on fire. You can get hives. We often have itchy skin rashes.
I have ants in my blood.
Yeah, we often get really just uncomfortable and like our skin will react to things that we don't think we're even allergic to just because, it's a new product that we're trying. And it also is related to
scratch yourself and it like raises.
And it stays like playing tic-tac-toe.
The bumps and the hives. Yeah, it's so bad. And then also it's related to GI upset because your immune system and the bacteria and the hormones that we have are really influencing our GI tract. And then it also can do with brain fog because when your hormones and your immune cells are overactive, it's hard to think straight.
Taking all your energy away. Wow. Thank you so much for going back and doing that because I think it was helpful to bring it all together. And I do just want to mention too that sometimes as someone with a EDS hypermobile, like we think that if we just supplement with collagen, then like it's going to improve the situation. And that's not necessarily true. And it can actually make your MCAS worse.
Right.
Some people are intolerant to like seaweed or high levels of salt, even certain types of salt. I have a thyroid condition, and so I'm supposed to avoid iodized salt. And so if I were to take those supplements trying to help my POTS, then I would end up sending one of my arms like totally off.
Yeah.
Real fucked up.
There's a big ass Venn diagram of all of these things when you have all these conditions together, and there's an overlap.
Yeah.
There's an overlap, but some things are really truly individualized. And it's important for healthcare to be holistic, but it's important for us to know that there's no cure-all at all whatsoever.
Yeah, and that's exactly what I was thinking. Like, I want to emphasize the fact that, like, if everyone just took a holistic approach and an individualized approach, that would be great. That would be great.
So we want to really emphasize the intersection of the trifecta, right? And chronic illness is always variable. Your symptoms will always vary. And one day POTS can be the most disabling thing that you deal with. And one day it could be EDS and one day it could be MCAS, depending on what's going on. And the sensory dysregulation, we also see that with ASD, the psychiatric symptoms, everything is more connected than we think, or at least it says in the textbooks, right? So, and we don't really know exactly which gene or blood marker this is, but there are so many neural pathways that are connected. So by trying to deal with one, you could be trying to deal with multiple, right? And we have all these connections in our brain, our nervous system, with our connective tissue, our gut and our brain, our immune system and our nervous system is all connected. So trying to think about these things individually is just more of a waste of time.
This is pretty much the part where you get to talk about everything you've been researching, right?
Yeah. I mean, there's a lot of future research to be done, right?
Yeah, because if there's not even an established protocol for what happens when someone gets diagnosed, totally. So you were telling us your super impressive research project. Do you want to share it with the class?
Yeah, sure. So I am an orthotist by trade. I'm board eligible, which means after I pass my exams this summer, manifesting, I'll be a certified orthotist. And what orthotics
That's a bone
is,
person. Yeah, sorry.
no, I'm not really an orthopedist.
Darn.
I am talking about the braces, the supports, the external supports that we use
Fake
to bring a strength where there's not,
supplement.
stability where there's not, to supplement things for people that have weakness or have some kind of physical disability, but nothing's missing, right? So prosthetics is the other half of that. I'm going to be entering my prosthetic residency to physically replace missing things, but bracing is really to supplement for what is there. So orthotics are a huge way that we can manage symptoms, especially with hypermobility in mind, because we can try to limit that hyperextension and physically, literally brace ourselves to try to prevent injury or to recover from an injury that's happened, right? So what I'm looking into is how can we use orthoses, braces, to try to support this population, because it's very anecdotal. It's very, we recommend orthotics for patients with EDS, but there's zero standardized procedure, just like in any other symptom management for the trifecta. For EDS, they recommend orthotics, but what kind, how, where, and with our pain always shifting and moving to other places, and the severity of our symptoms and pain always changing, how do we approach this? So I think the most practical approach that I'm looking into is proprioceptive bracing. There's kind of two theories that I'm working with. One is like building a brace that works like KT tape, that reinforces what our ligaments can't do, helps us to stop overcompensating with our muscles, but it's able to be replicated accurately and continuously by the patient themselves instead of applying this tape all the time to reproduce what our ligaments do. But the other half of this research is proprioception. Can we build a brace that isn't rigid and limiting our motion, that puts pressure on the right muscle insertion and gives us an indicator of where our body is in space, giving us sensory input where we lack it to try to help us produce a better posture and reduce the rate of injury and reduce our pain even. So it's a lot of theories. I'm trying to do proof of concept right now. And then in my PhD, I hope to actually design some orthotics to put to the test.
You're really cool.
Wow.
You're like a really smart, cool person. I'm just letting you know.
There's a lot of research that says that compression garments and body braids are excellent for people with limited proprioception and with HEDS. So that leads me right into, well, if we can enhance our proprioception and our sensory input, we can fix ourselves. We don't need a brace to hold us back, to stop us from hyperextending and limit our range of mobility and our independence. Why not work from the inside out?
I'm trying to connect it with something because I remember my friend sent me a video about a person with ADHD and how productivity is increased when they're wearing shoes. And I noticed the same thing with that, but also with these socks that are too tight. But it gives me sense of relief, and now I understand why. Do you think that that's related? Because people with ADHD can have proprioceptive issues, and so that's really interesting. I just linked the two, and okay, I know it's strange how our bodies know sometimes how to cope, and we
even when our brains don't.
Like when
I wear compression wear all the time. I wear athletic clothing whenever I get the opportunity to not dress professionally. I wear compression. I'm wearing leggings right now, and because I get more feedback from that, and I naturally just feel better.
Wow.
Yeah, my son's OT suggested that for his high sensory seeking behavior, but he hates it all.
With the sensory
but we'll
perception
figure it
and
out.
autism.
Yeah, I'm just gonna keep chasing him around and throwing him and stuff. We're just having lots of fun. Lots of play fun. Okay, so I'm looking at our notes here,
but it just shows the scope of what the multidisciplinary team can look like. And I mean, for MCAS with histamine intolerance, nutritionists should be on that team, right? So depending on what comorbidities you're dealing with, you want your multidisciplinary team to reflect all of your needs and not just one of them, right?
Right. And so it would be a situation where if a kid is being screened for ADHD, then maybe they might also be screened for Ehlers-Danlos.
Yeah.
Absolutely. We should have more diagnostic tools that are intersectional and holistic
Yeah.
rather than singling each of them out. And that
Yeah.
that same statement would go for treatment. Why treat them all separately?
You know, there's a
Amazing.
thing in child psychiatry, at least where I work, where we say comorbidity is the baseline. And it's strange
It's
because
the
adult
rule, not
psychiatry
the
don't say
exception.
that. Yeah, and so I'm just thinking not only obviously EDS, but I mean autism, OCD. I mean, you know, we shouldn't just have the tunnel vision. Yeah, I think screening programs, I mean, this is utopian thinking, but you know, that would be great. Yeah.
Yeah.
Wow.
Yeah. Routine screening for neurodivergence in kids with hypermobility and vice versa. That should be the standard. There's so much there's at least 50% overlap from all the studies that I've seen. An average of 50%. So,
Whoa.
and I mean, that's the baseline.
That's the baseline. Exactly. I'm really excited for your research. I love these ideas. I feel you're definitely filling a gap in the literature, and I'm
Trying
just
to
really excited.
standardize our care a little bit
Yeah.
where it's
Yeah.
lacking. And we have so much anecdotal evidence, but we're supposed to be doing research-based practice, evidence-based practice, right? EBS, or EBP. And that's what I've been taught in school. And then in orthotics prosthetics as well, we're lacking in that department because everyone wants to be in the clinic and no one wants to do research. And they just want to
Oh,
hire the
no.
engineer to make this thing and then see if it works. I come from that environment where I know how important research is. And when I fell into this world of EDS, it only seemed natural to try to bring them together and to try to influence that with research.
Which is amazing. Like
The question is, what can an OT help with? You know, the proprioception we talked about, you know, more, you know, sensory, you know, stimulation or awareness. But what else? And is it different when they're an adult versus child? Like there's different programs.
Yes. So
Women.
children are more adaptable and able
Yeah.
to learn new routines a lot easier than adults. And I think where the OT really comes into play is helping us not to compensate and do things safer. The number one thing that I ask all the people that I see regarding my EDS is, I love what I do. I love running. I love my job. How can I maintain that, do that for longer? So from a young adult or an adult perspective, it's about maintenance. And for children, I think there's more of an intervention.
Yeah.
Or like a preventative aspect to it.
Yeah. That's so
That's
true.
bittersweet. Like,
Yeah, it is.
That
Because
is-
how long it takes to get diagnosed. Yeah.
well, yeah, because I think it was me like 6 months ago. I was like crying, like, I have to do these exercises for the rest of my life or else I'll be disabled. But then I finally had that moment where I was like, all I have to do is these exercises and then I won't be disabled. And it was
Yeah.
that subtle like shift in my brain that I was like,
Yeah.
okay, it's fine. Like, it's fine. But I mean, I don't know. Most people on the street aren't going to look at me and be like, yeah, she's sometimes disabled.
Right. And that's the same thing about being an
Look at
ambulatory
these
wheelchair user.
muscles.
You know, it's invisible.
But I still have the flabby skin despite the fact, well, actually not, but I can pull it down a lot. Like, that's a lot, right?
Yeah.
Anyway.
Skin and extensibility, but also being strong and trying to stay strong to help keep everything together. And it's just this, you're
I'm
always
trying to
chasing your
hold it
tail.
all together, guys.
Always chasing our tails a little
I
bit.
didn't realize I had to like push my chest out. I thought that was like a weird, and that's just how to arch your back. That's just how.
Yeah.
I
The
don't know
number one
why
thing
when
I
you
think
said
is,
the
sorry.
chasing our tail, it reminded me of that Greek mythology story, Sisyphus, who
The
keeps
snake.
pushing the rock uphill and then having to do that again and again. And I know that's a metaphor for
Yeah.
life in general, but I
Mhm.
feel sure people with chronic illness understand that more than anyone else. And that's
100%.
a thing that you have to go through.
Number one thing
Yeah.
that we can do to try to supplement that feeling is find community and find other people, I think, that understand what we're going through. And it helps us so much. I always say this with like all my patients, schedule all the babies that wear helmets at the same time and all the transfemoral amputees at the same time, because they will have figured something out throughout the process of being disabled or the evolving disability, and they can share that coping mechanism or that tip with somebody else. And it helps us so much to have a sense of we're not alone, but also, what do you do? What works for you?
I mean, that's amazing, by the
Something
way.
different.
This is, you know, thinking about those little details, like just arranging appointments where people that are similar put together for a community is so simple, but it's so amazing. And not a lot of people put that extra effort. So I just got
Very effective
goosebumps when you said that. And I'm so happy there's a person like you
not
out
everyone
there.
wants to go to a support group, but
Yeah.
if they're in the waiting room with someone who's exactly the same, they might get to chat. It's just more organic.
Yeah.
That's so true.
Actually, I think I just to segue into segment 4. And if we don't like this segue, Sam, we could do yours too.
All good.
But just because, so we were talking about how, if you're walking on the street, you might not know that someone is disabled. There are plenty of invisible disabilities. And similarly, well, these are, I'm kind of saying 2 ideas. The first idea is an invisible disability. The second is that I think similar to ADHD and autism, there's a lot more awareness of hypermobility and hypermobile Ehlers-Danlos syndrome now. And I think POTS as well, which is great because people are getting diagnosed. And I know that I had an awkward experience when I went to a cardiologist to try to get diagnosed with POTS. And she was like, all these 20-year-olds are coming in to try to get diagnosed with POTS. Like, you shouldn't want to have POTS. And I'm like, no one wants to have it, but they're coming in for a reason. And I think that this kind of these 2 ideas segue nicely into kind of our last area of advocacy, care models, and just kind of summarizing everything up. But
yeah.
Nicely done.
Wait, there's a bigger community out there than people realize. EDS is typically associated with the zebra metaphor. And the zebra metaphor is basically like the doctor's looking for a horse, but it's actually a zebra or something along those lines, where you think it's going to be something more common and it's actually a rare disease or a rare illness. However, I have a huge problem with that. I don't think that we're zebras. It's really difficult to estimate the actual prevalence of HEDS because of all of these different ways that we try to diagnose it and all of the misdiagnoses that are going on. And the highest prevalence recorded is estimated at 1 in every 2,000. But that is considered to be a gross underestimation of how prevalent it actually is. And that, all things considered, a rare condition is considered 1 in 2,000. So if we're assuming that the prevalence is more than that, trying to take the stereotype that this is a rare condition away gives us more space, gives us more access to be included in the conversation, more funding, more research, and all of these things will be easier to come by. Because as soon as you say, oh, it's rare, physicians don't want to educate themselves about it. I want to allocate resources to that. This metaphor of us being zebras is actually more harmful than good.
Yeah,
And
it's not
also
rare.
1
It
in
actually just takes
2,000.
us 2 decades to get diagnosed.
Yeah, and also
Yeah,
rare 1
exactly.
in 2,000 is 1 in 2,000 is still a lot because last
It
time
is.
I checked, we're 6 billion. So 1 in 2,000 is a
Yeah.
lot.
It's actually
It's
really
a lot.
common. And if you had 100 people in a room, like the prevalence is it's higher than you think. And the
Yeah,
highest
definitely.
estimated prevalence is 1 in 2,000. So, and we're assuming that's low.
Yeah, and it's a
Love it.
totally like self-led diagnosis thing. Like you have to be like, no, there's something wrong with me.
You
No,
get
do
yourself to
this
the point where
test.
you're actually hysterical because people are convincing you you're crazy.
Yeah.
But that's why advocacy is important, and hopefully podcasts like this help raise awareness so you're able to articulate what's wrong. I think, again, because if you're born with this, it's really hard to realize what is the other side. So advocacy should be from physicians as well, but with patient knowledge, you're being able to advocate for yourself even more. And with a community, you're going to be able to advocate for yourself even more. So yeah.
The benefit of the zebra thing is if you are looking for a community, then you can like look up like zebra EDS on Facebook and then you'll find like support groups, or maybe there's one on Reddit or something. Because even though it's probably a misnomer, it is the symbol that we have.
Yeah.
I'd like to share a quote really quick.
Yeah,
Sorry.
please do. No.
So Doctors Hakeem Tinkle and Van Kimona from 2021 in a study said, The conclusion of their study was the belief that EDS is rare or ultra rare is true for several forms of the syndrome, but increasingly the hypermobile type of EDS is thought to be more common, and hypermobile spectrum disorder much more common. Yet often the journey to diagnosis and treatment is challenging for patients who may receive no diagnosis or a misdiagnosis. In addition, misconceptions that the issues are solely mental health concerns are commonly reported. So it just kind of concludes that the journey to getting diagnosis is so rocky. It's just filled with so many barriers and problems. And the fact that individuals who are in this community may never even receive a formal diagnosis, and that they may be written off as solely neurodivergent, even though it is something, it is not what we're looking for. And that just shows why the estimated prevalence is probably so low. Because if we cared enough to have standardized diagnostic procedures, we wouldn't be zebras. We need to have a neurodivergent informed approach as well, because it's not just enough to know enough about EDS. We spent however many minutes talking about comorbidities, and that has to be part of the conversation. You can get diagnosed with POTS and MCAS, and that physician or specialist should also know to test you for HEDS and increase the prevalence in that way.
Yeah, it's interesting. In med school, they sometimes, when there are so many associations between diseases, can put them together, even if it's not in the same person, in families, like you need to look for this. I've never had that kind of association. And I hope in the future, in med school, it is taught like this is more common to happen with this. Please look for that as well as this. And that would change a lot of things, because then you would have it in your mind to look for it.
Yeah, I think it just reminds me of going back to like the holistic approach, kind of what we've been talking about. If that could be kind of a standard, that would be great. And I know it's probably a lot more front-loaded work, but yeah.
Advocating for yourself.
Yeah.
I really think that once we get the doctors sort of connected on like a platform, and like maybe where like everybody's on my chart,
Oh,
and then,
yeah.
like you can be doing like self-assessments on there, and then it'll automatically flag the results to your doctor and then tell you like you scored above threshold for this one, you should probably take this one.
Yeah, that would
and
be
I know
cool.
that
like better to
we
program.
have the technology for that.
Yeah,
but
like
we don't have the money for that.
Well, because
okay?
Well, no,
So
it's
that's
the doctor's
future
office
that
wants
we
to
need
bill
to
you
demand.
personally.
It's not even their fault. It's the health. Anyway.
Yeah,
No,
you're
right.
right.
But like you're saying a great point, because
we're all
I was
wage
just
slaves.
saying, I was like, oh my God, like it would be a lot more work for doctors to like be aware of all of these things. And yes, like that would be great. But also we have modern technology.
We have technology.
Like, where it will be easy to program.
Yeah.
Like if this, then this. Like that is something that seems like within our grasp.
That's the easiest thing to code.
Yes.
It's the money. It's the money.
Yeah.
It really is.
Who's
I'm
gonna
just letting you
invest?
know. It is, like, trust me, we have so many people who are, so devoted to a specific, even like a rare disorder that they're trying to get funding for. But we can blame doctors. I'm all for it for a lot of things, I'm all for criticizing and even seeing some things that I'm doing that I need to improve. But this time it's the money. It really is the money.
Yeah, for sure.
But that's the future, people. The future is accessibility for all. The future is mobility aids for all. Proprioceptive aids, what?
For all.
Yeah, that's wild. Amazing.
Holistic approaches.
I think we did that thing.
I think we nailed that thing.
Times 2.
Woo!
Woo!
Yeah. Thank you so much. Soon to be Dr. Sam. Your
Thank you.
knowledge very much appreciated. And
definitely if there's anybody listening who sort of relates to this whole fiasco, as we said, we're going to have a bunch of resources available for you to do some self-learning. If you want to reach out to us on socials, we are active on TikTok, Instagram, Threads, etc. Come join the party. Come talk about like weird body stuff with us. It's fun.
And that reminds me too, is that whether you relate to the hypermobile stuff, or maybe you're just someone who follows us for the neurodiversity content and they're just happening to listen to the end of this, a reminder that we also want to hear the stories of our listeners. So if you or you have a friend that want a platform to talk about your story, your journey as a neurodivergent person, but also if you want to like build community, like we would love to meet you. We love to make new friends. And yeah, so we have a link on our website if you want to just be on a listener. We call them like the listener interview episodes. Like we'd love to have you. So yeah.
Yes.
Yeah. Okay.
Sam, do you want people to find you on the internet?
That would be super cool. So I am an advocate for my field for orthotics and prosthetics. If you have any questions or interest in that, I'm an advocate through ABC. So What is POP is the website for that. So I'll be accessible through there.
We can add
I'm
a
on
link.
social media and I love talking about what I do. I could do it forever. I'm looking also for people to peer review my studies right now so that they are publishable, so that I have what's called currency to go to get my PhD. Currency is like funding and publications and things like that. So if you are in the field and you want to give feedback on my papers, that would be super appreciated as well.
And then what would be the best way to contact you then?
We can link a couple of my emails
Okay.
down below. Social media is also totally fine.
Okay, we'll link them all.
Thank you.
Thank you.
Awesome.
Yeah. Well, this has been the Neurodivergent Report.
Yes.
Yeah. Thanks again for listening. Or no, sorry. Thank you for being here. That's what Sarah always says, and I always really like it.
Yeah.
Yeah.
It's also in it as like the outro clip too. That's how it starts. It's like, thank you for being here. I
Yeah.
enjoyed this podcast. Please don't skip my outro.
No.
That was fun.
Yeah.
That was a really good time.
Thanks for being here. If you want to connect with the Neurodivergent Report, you can find us at ND Report Pod on Instagram, Threads, TikTok, YouTube, Blue Sky, Substack, etc.
If you're looking to support the show, the best thing you can do is subscribe and leave us a 5-star review. Please do that.
And hey, if you want to check out more about us, visit our website at ndreportpod.com. And you can also go there if you want to be a guest contributor on the show.
Until next time, be well, do good.
Bye.